Hi, everybody, and welcome to the InTouch Health webinar series. This is Scott Young, and I'll be your host for this webinar. Today, we're featuring Morgan Waller of Children's Mercy Kansas City and LuAnn Talley of InTouch Health, and they're going to be presenting on Telepediatrics.
Sorry, this is LuAnn Talley, and I'm not sure if the rest of you were having some audio difficulties. I know I was having difficulty hearing that, but why don't we go ahead and launch right into the presentation. I hope the audio is better as Morgan and I are speaking. And again, welcome. We really appreciate everyone joining this morning. At the JP Morgan conference last week, an overarching theme was the healthcare industry's continuing move towards value-based care. The challenge is building or buying the necessary infrastructure, tools, and partnerships with organizations looking at innovative ways to get there. Virtual care, or telecare, is generating more interest and being increasingly adopted, thanks in part to better and broader reimbursement by most payers as a means to deliver value-based care. By improving access to care and clinicians, supporting improved clinical outcomes, improved clinical outcomes, enhancing the care experience for patients, their families, and providers, and can reduce the total cost of care. This webinar is focused on one leading children's healthcare provider's experience to derive value-based care and outcomes for children, adolescents, and their families. InTouch is thrilled to have Morgan Waller, Director of Telemedicine, Business and Operations with Children's Mercy Kansas City, as our guest presenter today. Morgan will be sharing her vast experience and insights into delivering virtual pediatric specialty care in more than 30 clinical specialties. Telecare can be used across the entire care continuum to create a connected care experience and better manage population health. This is especially important and relevant as integrated health networks, ACOs, and risk-bearing organizations aim to keep as much care as possible within their own health network. This includes direct-to-consumer, ambulatory, and community-based care, which includes primary and specialty care performed in physician offices, clinics, schools, and other community-based settings, acute care delivered within a hospital setting, post-acute care, which includes rehab centers and home care, and remote patient monitoring. For population health, you need to be able to connect all care sites, inside and outside the four walls of a hospital, including physician offices, ambulatory sites, urgent care centers, home, and more. Additionally, you want to be able to connect with consumers using their own devices and digital health tools. InTouch enables these care connections due to our low bandwidth requirements and through our ability to integrate with disparate EMRs through various interfaces and APIs. This chart shows a sampling of the wide variety of use cases for pediatric and neonatal virtual care, which are virtually endless. In November, InTouch hosted a webinar with the Mayo Clinic sharing their experience in teleneonatology. Today, Children's Mercy is going to share their experience and learnings providing telepediatric specialty care in more than 30 specialties. Other use cases for teleneonatology and pediatrics include ED support arrangements for pediatric specialty coverage. This, in some cases, can avoid the need for transfer, benefiting both the telehealth provider if they are at capacity and remote care sites. Hospitalist and nocturnist coverage, especially for after hours and weekend care, access to clinical trials, training and education, including telementoring or proctoring for new technologies or treatments, bundle payments such as mother-baby care, including lactation consulting and postpartum depression, and pre- and post-transplant care. And strategic alliances, where the pediatric provider is building relationships with community providers, rural hospitals, FQHCs, and others to enhance access to quality pediatric care, improve affordability, and enable the child and their family to remain close to home for specialty care. Lastly, I'd like to share a few ways that health systems and providers can measure population health by tracking health improvement using quadruple aim measures. Some providers evaluate telehealth based on ROI. However, innovators realize telehealth extends beyond pure economic ROI. You can develop a similar set of quadruple aim metrics for any clinical use case. These are just a few examples. Improve access. Pediatric specialists are generally located at children's hospitals or major medical centers in regional markets. Telehealth enables these providers to deliver expert pediatric care to children and their families closer to home, thus removing the need to travel for certain diagnoses, treatment, follow-up care, and managing chronic diseases. Better outcomes. Teleneonatology and MFM, or perinatology services, have been demonstrated to improve birth outcomes. Total cost of care, or affordability. Telecare helps to leverage specialist capacity and efficiency to better manage the total cost of care. Care experience. Telecare has been shown to improve Net Promoter Scores among patients due to improved convenience and can enhance provider recruitment and retention through enabling flexible and remote work schedules. Additionally, you can capture real-time patient and provider experience data using Telecare immediately after each visit or encounter. Now, I'd like to introduce Morgan to share Mercy Children's experience with pediatric specialty care using telehealth. Morgan?
Thanks, LuAnn, and thanks InTouch for hosting this webinar today. I'm excited to talk about telemedicine, and I'm very much looking forward to questions. That's my favorite part of any presentation that I give on telemedicine. So I have a background in pediatric critical care and information systems, some education, a few degrees here and there, but the most important point on this slide is a general distaste for being told no. At least 6-7 years ago when I started working in telemedicine, that was the most important characteristic, tenacity and persistence. So Kansas City is smack dab in the Midwest, right in the middle of the country, and Children's Mercy in Kansas City sits on the Kansas-Missouri border. All of our providers are licensed in both states already. That was something that was in place even before telemedicine because we have an inpatient hospital and clinics on both sides. And then the nurses are also licensed in both states. So that has actually been a huge help to me starting in telemedicine. I just have to deal with the other surrounding states and licensure barriers. So Kansas City is here again. This is to demonstrate just how rural we are. There's a lot of information about what telemedicine can do for rural communities to improve access. I certainly don't believe that telemedicine is limited to rural areas. It has applicability anywhere geographically, but we definitely have a situation where a lot of kiddos, it's 9 hours to Denver, which is the next children's hospital to the west, or major medical center of any kind, 4 hours to St. Louis, and then we're right in the middle of a 7-hour drive between Omaha and Tulsa. So our catchment area is very large, and as you can well imagine, it is very difficult for someone who needs a specialist in western Kansas to make the trip to Kansas City every time they need a follow-up visit. I will also want to mention that InTouch's Telestroke program, and yes, I'm definitely plugging for them because this is an absolutely amazing thing. It's made such huge differences in people's lives. Kansas has more critical access hospitals than any other state in the nation, and Telestroke has empowered those access hospitals to partner with major medical institutions like the University of Kansas Medical Center to get stroke specialists to treat patients. So I just want to say that this is a really good illustration of how effective that model of telemedicine can be. So our metro locations, this is the look of Children's Mercy in Kansas City. The mothership, if you will, is in the process of a facelift. We're actually building a research tower. So the traditional Adele Hall campus is going to look like this soon. And then, again, I said we had an inpatient hospital on the Kansas side and the Missouri side, and then we have clinics represented north, south, east, and west. We're 367 beds combined inpatient, 352 overall outpatient visits, not output, outpatient visits last fiscal year, 191,000 ER and urgent care visits, This is just to give an illustration of our size so you can put into perspective the last number, which is my absolute favorite number, the 2,341 telespecialty encounters that we did last fiscal year. We're definitely improving access, not just in the metro, but also in our regional outreach locations. And I promise this is not a geography lesson. I just want to give perspective because I don't know how many folks that are listening have traveled to the beautiful Midwest. So we have regional outreach clinics in St. Joseph, Junction City, Wichita, and Joplin. And Wichita is about a 3.5-hour drive from Kansas City. In 2012, I started under the leadership of our CMIO, Dr. Fitzmaurice, with one telemedicine patient I inherited and aspirations to start telemedicine. I took it very seriously, and we're forecasted. Our team is so excited for 3,400 telefacilitated subspecialty visits this year. We've been in the news lately. Headlines are always exciting, and not just because of the number of encounters, but also the number of specialties that we have that are practicing telemedicine. So we've been able to onboard at least one provider from 30 of our 47 specialties to offer telemedicine to their patients in those 4 regional outreach locations. And then we've had an average growth rate, annual growth rate of 73% in the number of encounters since we started. This is a bar graph illustration of the number of encounters, the growth, and then also the change in the last 3 fiscal years of number of specialties practicing. It is well established in the literature that consumers love telemedicine. There's so much evidence, you could say it's factual, that people love telemedicine. We did ask, because I was curious, what is it like compared to an in-person visit? How do people rank it? So yeah, they love telemedicine, but how do they love it when they're thinking about their last in-person encounter? So that's the question we ask. We ask several questions, but the big one on the survey is thinking about your last in-person health care encounter. How did today's telemedicine visit compare? Was it as good as, better, or worse? The first quarter of this fiscal year, we had 100% of our 156 respondents answer that it was as good as or better. And this better piece is significant because now we can start asking questions about, well, why was it better? And getting at the real reasons for, some of it is truly common sense, we know, the driving and things, but why is it a better experience? Again, another way of looking at our growth, because I measure everything I can get Chad to put on a graph for me. I wanted to show this big. The most recent change in our numbers is a significant growth in number of visits per month. And the reason for that is we have been able to hire 3 part-time, full-time telemedicine providers. So these are providers, specialists, highly sought after, that were going to leave the organization for some reason or another. And we were able to retain them by offering them the flexibility of continuing to work for Children's Mercy, regardless of where they were going to be moving to. 6 states away, we don't care. If you'll continue to see your patients via telemedicine, we would be delighted. This has worked out fabulously for us, and I have to really applaud and be grateful to administration for supporting this, crazy new idea. I don't think it's crazy, but I think you can appreciate sometimes my wonderful ideas are not always considered wonderful by other people. So I'm diplomatic with that. What does our program look like? It looks like a clinic on the inside and outside. It looks like a specialty clinic. We have access reps, care assistants, these wonderful RN telefacilitators that I keep talking about. The difference is we have RP lights and beachies instead of providers in person. This is our amazing Dr. Escobar. pulmonologist was one of our telefacilitators. Children's Mercy owns and operates both the patient and provider sites. As I said, we have those regional outreach centers. Live interactive two-way AV with ancillary exam devices and facilitators. Incidentally, we have that templated into the provider note, so they don't have to write it every time, and it helps to ensure that the coders get the right level of encounter, so they don't consider it to just be AV. They know that we have the ability to replicate the same standard of care for a level 5 encounter. The telefacilitators are not, they're BSN prepared, and they have to have a minimum of 5 years experience. Uniquely, they report to telemedicine and not patient care services or nursing in general. We follow all of the same rules and regulations, however, but they are virtually supported and led and made part of the team over distance because I knew we could do it. I trust my team immensely, but we're actually, practicing this whole virtual concept in many different ways, proving that people can be trusted and autonomy is a great thing. The telefacilitators have thrived. So this is a beautiful picture of our Joplin Outreach Clinic. We have an artist called Scribe that does all of our artwork in all of our locations. And then again, Dr. Escobar with a telefacilitator in Wichita. Do you have to build a $1 million clinic to host telemedicine encounters? Emphatically not. These locations were originally put together with the idea that physicians, advanced practice nurses would live and work in these locations. That has proven to be a little bit more challenging than originally thought. Wichita, because it is the largest of those areas where we have these outreach clinics, does have providers that live and work there for cardiology and endocrine. But the rest of the locations have just thrived with telemedicine. We offer more clinic blocks than any of the traveling outreach in-person efforts, and we're offering 30 different specialties. So really, I am super fortunate because I get to take advantage of these amazing buildings. You could say I'm spoiled in that regard. It is absolutely not necessary. It's wonderful and I appreciate it, but I think that you could use the same type of model and have a couple of clinic spaces that you're renting in a rural area and do the same quality of work. How does our program operate? Definitely a centralized model. I feel really strongly about that. Most common sense articles about telemedicine will talk about how organizations have 6 or 7 different types of technology, and they've had telemedicine efforts started rogue by individual departments that wanted to do telemedicine before maybe the organization was ready, and how do you bring that all together so you're not, having contracts for the same equipment by several different vendors, et cetera. We started out centralized, and yes, there were a few little things that I just covered along the way that had been started, but everyone was really embraced having a department that handled the telemedicine business, if you will. And I joke that, all telemedicine goes through me. Yeah, well, sort of. I mentioned I report to our CMIO and Executive Medical Director, which is, again, a little unique. A lot of telemedicine departments report to IS. But we're really a provider full-service team as well as focused on patient-centered care and providing the best provider as well as patient experience. Providers are burdened already enough, same with nursing, which I'll talk about why we decided to hire our own telefacilitators. They already have enough to do, and that's one of the barriers to adoption. So Dr. Fitzmaurice was very supportive of me just removing those barriers. If, a provider doesn't have time to start a telemedicine program, we're going to start it for them. A RN doesn't want to be a telefacilitator, we'll hire our own. So it has worked out so well. Besides myself, our team consists of part-time medical directors, clinical and training manager who is over all of our telefacilitators and new initiatives, as well as a general telemedicine manager who is mostly over our technical team, but he is also an EMT, so he does new initiatives and works with our transport, emergency preparedness, and ED and urgent care initiatives. A training coordinator that works with the providers to make sure that they're comfortable with the technology, they understand how to chart, that they have she works with the medical staff office to ensure that they have their credentials and privileges. Asynchronous coordinator who handles our teleradiology, tele-EKG, or tele-echo, as well as teleneurology initiatives and our contracts with organizations outside. So if we partner with an organization that is not a facility that we own ourselves, she handles those OH contracts. I passed over our part-time research coordinator. She lives and works in Wichita, so she's also managed virtually. She's currently working on efforts with Sprout, which is a national initiative to coordinate pediatric telemedicine research among all children's organizations that are interested in participating. We have the senior network and video analyst, our technical support, and then an AV design engineer, the clinical telefacilitators, and care assistants that report to us. And there's a little beachy and a picture of artwork in Wichita. Some of you might be going, oh my, she has a lot of staff. How did she pull that off? Well, I'm busy, and I'll stick my nose into anything if it has video in its title. And we do it all. That's how we've been able to be so successful in onboarding as many specialties as we have, and to increase the number of encounters, to get the word out. Is that it's not my job syndrome does not apply with my team. I think no one on my team would say that, at least where I could hear them say that. So it is my job, even though it's not. Oftentimes it's not. Certainly in the beginning, it's much better now. But if we needed something, oftentimes we had to learn it ourselves. I became an expert in, legislative advocacy and contracts and fair market value. What is that? Oh my gosh. I have nightmares about fair market value. SOWs and drop packets and black market for face sheets. You name it. You just have to learn it. The tides have changed, to use a cliche, in the sense that telemedicine is becoming so much more mainstream that we get a lot more assistance than we used to. And it is definitely a welcome breath of fresh air. In addition to the following slide that you'll see all of the specialties that are practicing, as I mentioned, our asynchronous program does radiology, neurology, and cardiology and the contracts. And she works with credentialing and any licensing issues for out-of-state. We also handle any video conferencing or AV collaboration. For example, radiology and surgery can view an image, the same image at the same time during a surgery. We set that up so they could collaborate if necessary, which they could do before on the phone, but we added that visual of being able to see the MRI or the CT or the X-ray at the same time that they're talking about it. Huge quality measure, safety measure. The surgeons and radiologists really, really appreciated that. We also handle video solutions in the ORs, so we work with Carl Storrs and our providers to make sure that that everyone is taking advantage of all of the functionality of the devices that we have, and we just provide oversight there. I mean, it's still the OR's thing. You know, we try very hard not to step on any toes. We're just here to help to make things easier. And so there is kind of a source of truth, if you will, with regards to our video initiatives. Kid Care Anywhere is our direct-to-consumer platform. We do interfacility consults. So between our Kansas location and the Missouri inpatient location, if an inpatient kiddo at Kansas needs a consult and the providers are at main campus and can't get away, it's way more efficient to offer that consult via telemedicine. And then, like I mentioned, we have some rural access hospital partnerships. So I'm so proud of this slide. I love it. It's a list of all of the specialties that are doing telemedicine. We have a saying that if child abuse and neglect can do telemedicine, or if rheumatology can do telemedicine, anyone can do telemedicine. So that one of the barriers that providers, very rightfully so, will express is that they are not comfortable, or they have to be able to touch the kiddo, and they don't have any control if they're not physically there with the patient. So we offered, again, knocking down those barriers, to have our telefacilitators come to Kansas City and spend time in clinic with the provider, as long as it takes. This was what, we said to the first rheumatology provider that started. Her section chief was all about it, great leader, we're going to do this. But she was really reluctant and nervous because providers are so conscientious about their practices and their patients' well-being. I'm like, she's going to come and work in your clinic with you for as long as it takes, until the two of you are comfortable and you've built a rapport and you feel like you can trust her to demonstrate, because our nurses don't practice outside of the scope of nursing, to demonstrate the physical exam that you need in order to take care of your patient. So we launched them in like 6 weeks. This was several years ago, and we've moved on to add other rheumatology providers. Scan was a similar thing. That has worked out. We've had to add some additional cameras and equipment because sometimes those need to be recorded or different angles need to be taken, but we've just made it as easy on the providers as possible. We set up the practice. Another thing that I feel super passionate about, which is kind of a leadership thing more than maybe a telemedicine thing, but I am a consummate critic of customer service experience, my own and watching other people. And I have a whole catalog full of bad customer service experiences from which to pull on. I don't want any one of our providers or patients to have a bad customer experience like that because of telemedicine. And that's my passion. That's where it starts. Everything else, goes from there. It has to be a great experience, and we have to forecast that it might not be and try to figure out how to ensure that it is going to be a great experience. We have a telemedicine provider helpline. I think that's, I've heard Julie Hall-Barrow talk about, they have the same type of thing. It's essential that providers can get help with telemedicine immediately. Based on our satisfaction survey, you can tell it's pretty rare that we have any technical issues, but if we do, or maybe it's a training issue or they forgot how to use something, so it doesn't always have to be technical that they're having a problem with. The other thing, and it may be on another slide, that is if there's a negative patient family comment, it is usually because of the technical compromise. Again, it doesn't happen very often, but it's very valuable to ensure that you have assistance. So the patient's words are the best. I can go to administration and our executives and say that, there's a ton of research out there that says people love telemedicine. We really need to invest more in our telemedicine program. And it's a whole different thing if I show them the results from our experience surveys. And share some of these quotes. They are so heartfelt, and I love things like, this is a good thing on so many levels. Telemedicine has helped us in so many ways. Excellent visit. We were just going to try it, see what it was like, or if we were going to like it. And we loved it, and we're very excited to continue our care via telemedicine. One of the best doctor's appointments that I've experienced. Wow, is that because of the provider that is drawn naturally to telemedicine? Or is it because they didn't have to drive 3 hours and wait in the waiting room for 2? What was it about? Was it because they could see the exam, some of it, the inside of the ears or the inside of their throat? Because a lot of the digital exam equipment gives an image through the InTouch screen, allowing the family to see what the provider's seeing. You don't get that in a traditional in-person clinic. Just loving the fact that we don't have to drive. I like this one too, because certainly talked about it and the literature talks about it, but this family recognized that this is a good thing for the community, that we've set these clinics up in those communities and we're bringing Children's Mercy expertise to their community. This kind of stuff makes me really love my job. So on the surveys, we also ask, why did you choose telemedicine? We don't force patients to have a telemedicine encounter no matter how far away they live. We give them the option, and about 79% of the people that we ask, which would you rather have, choose telemedicine. So why? Oftentimes we're able to get them in sooner. I wish I could tell you exactly why that is the case, but it's still a little bit of a mystery. But availability in our clinic blocks at those locations sometimes is much sooner than if they had to come to Kansas City to the main clinic. We didn't want to switch doctors again, and we were able to do the same thing with the robot. So I think that is a comment based on one of those providers that, for whatever reason, we're going to have to leave the organization and chose to stay continuing to care for their patients via telemedicine. That's a patient-centered as well as brand loyalty when you offer that type of service to your patients and families. I couldn't drive the 2-hour trip. So, and there's a lot of people that is true. They can't take a referral or a follow-up appointment because they just can't. They don't have the resources to drive, or their employer won't let them off. This is so much closer to home. So my child's not going to miss a lot of school, and I'm not going to miss a whole day at work. We needed a pediatric specialist near us. So maybe this provider only offers, some of our providers or departments will travel in person for an outreach clinic, and some just do telemedicine. So maybe this is a situation where there was no one local, and telemedicine was the only option. And here's another one that's great. I don't want to have to take 2 kids and a preschool kid and travel. Make those arrangements for either childcare or worse, I guess, have them all in the car for a 3-hour trip to the metro. Truly examples of value. Some more why about telemedicine. There's absolutely nothing wrong with convenience and efficiency. It's difficult for a lot of us to get our kids, thank goodness they're healthy, to their well checks every year and their dental appointments every year. I have so much empathy for families of children with a chronic condition where they have to go to the doctor 4 times or more a year, in addition to their well checks and their dental visits and whatnot. So this picture, although that's the healthiest looking kid you could possibly find, presumably looking for a direct-to-consumer telemedicine visit. So it's just my joke about marketing. At any rate, it illustrates all the roles that we fill daily and why telemedicine offers value in so many ways. So all right, it's 12:39. I want to make sure we have lots of time for questions, so I'm going to try to kick this up a little bit here. I'm on slide 25, so I think we're good. You might want to know how to create telemedicine success, and I am certainly not the be-all, end-all. I think that we know a lot about what works and what doesn't here at Children's, but there are infinite possibilities. As we embrace this point in history, really unlike any other before, where the mysteries of numbers and time are producing unprecedented advancements in technology, to achieve success and maintain it, you've got to pay attention. So, some of the stuff that I've sweared by may change next week. But this is stuff that's worked for us. I'm going to assume that your CEO and executive level leadership want telemedicine. They're already bought in, and they support a centralized model. The Mayo Clinics have a lovely publication on their centralized model and what they did to centralize their disparate telemedicine solutions. And then I'm also going to assume that you've already selected a high-quality telemedicine solution, devices, yes, like those produced by InTouch Health, because they, for the second year in a row, made best in class, KLAS. It's their research recognized InTouch once again as the highest rated for overall performance. So congratulations to InTouch. I'm not being paid. I just think you guys are awesome. So you want to start with providers that want to incorporate telemedicine already. There's plenty of them out there. Find the ones that want to. It's great that your strategic planning department or business development department has some numbers that say this is where telemedicine is going to have the best ROI or it's going to save us the most money. But if you want to not have to pull your hair out, start with providers that want to do it, and the rest will follow. The trifecta that anyone who's worked with me since the beginning knows that we came upon this trifecta. We're only going to entertain initiatives that have billable services where we can meet all the rules and regs and get reimbursed the same as we would if it were in person, and we do. Only initiatives that complement existing strategies or goals. I want to save the world, and we're going to do that next. But in the beginning, we had to really focus, okay? And it wasn't the time to start some brand new initiative that was just telemedicine and that we might get paid for and we might not. So, focus on stuff that's complementary to your organization's goals already. And then the division director or section chief has to be either a true champion, and that doesn't mean that they say they're a champion. Or they have at least said, I'm not a champion, but I'm not going to stand in the way of anyone who reports up to me from being a champion themselves. So those are the three, and those are still the three requirements when we're entertaining new initiatives, although we do branch out into some other things because we've kind of established that we're not as crazy as people initially thought. How important is technology? I mentioned that again earlier. So once again, even your biggest fans of telemedicine, you're going to lose them if they don't have quality and reliability. It's just not worth it. We tried. I'll be completely transparent. We looked at there was a period of time when InTouch's solutions didn't cover all needs, and we looked at some other solutions, and it was painful testing those. It just didn't work as easy, and just in the nick of time, InTouch came out with a whole suite of solutions. So now if you're engaging in that initial contract for telemedicine, you can get every variety, every type of solution and device to meet all of the different ways of offering telemedicine. So it is super important to get your technology investment correct. More on centralization, really great for everyone. then everyone knows whose job it is. It's Morgan's. No, my team would laugh at that. When I say we, I mean you. The evolution of telemedicine has really knocked down a lot of barriers. Really, it has. So if you're just getting started, this is an okay time. Really, it is. We feel like that we've made it through most of the barriers, with the exception, I mean, obviously Medicare could do a lot more towards reimbursement and getting rid of some of their limitations on patient location and whether or not you live in a rural area, but it's moving in the right direction. It's going to happen. And so the barrier that I think is remaining for us is consumer telemedicine literacy. Just because you build a telemedicine program does not mean that the patients are going to come. Like, we cold call a lot of people and say, hey, we noticed that you live closer to Junction City than Kansas City. We have telemedicine there. Would you like to switch your appointment? Or would you like to have a telemedicine appointment in Junction City? I see you're calling from someplace closer to Junction City than Kansas City. So plan on a lot of marketing, and you want marketing to be appropriate for the audience. I think mailing is a little bit outdated. So with that, you want a scheduling expert. We have Cerner. All of our documentation and scheduling is done in Cerner. Our providers use two screens, one for InTouch and one for Cerner. Works great. Everything is put where it needs to be. Don't have any worries about interfaces or PDFs being lost in the electronic health record. The documentation is all there like it normally is. You want to double check everything, get as many telemedicine reports as you can, and then don't argue over small things. If the department doesn't want to buy a spirometer, even though they buy spirometers all the time, if they say it's telemedicine's responsibility, just buy the darn spirometer. You'll move along faster. This is some thoughts on telemedicine strategy. I'm going to skip this and just say that strategic planning isn't necessarily strategic thinking, and I think that it's really, really important to be a strategical thinker and support the appearance of integrated perspectives and visions anytime, any place, from anyone in the organization. And inventing new categories is what strategy is all about, not just rearranging old ones. The Grinch thinks that perhaps it's much more. One day telemedicine won't need its own strategy, because the strategy is going to be to allow patients and providers to achieve their own strategy. I think this is a vision. We're still in a place where telemedicine needs a strategy, but I think we'll get to an integrated, where telemedicine will be integrated in everything and it won't have to have its own strategy. Sustain and scale, measure everything you can catch so you can prove what's working and what's not. The Mayo has a centralized program. They use all InTouch equipment. They own both ends in a lot of their initiatives. They have an enterprise strategy, and they do adults and pediatrics. So if you're looking for an adult situation, I think many of the things I shared today could easily be done in an adult specialty clinic. But if you want another example of an organization that's very successful in telemedicine that does adults, the Mayo Clinic. Additional resources. My team has several publications in a feature in a recent issue of Current Allergy, Asthma, and Asthma Reports. And I've got other stuff I'm always happy to share. Whew, okay, LuAnn, I'm going to turn it back over to you.
Thank you, Morgan. That was wonderful. I hope everyone learned a lot. In terms of time, we have a lot of questions that have come in, so I'm just going to start fielding some of these to you, Morgan, and let's just get started and see how far we can go. What specialties are in highest demand for telemedicine and why?
The same as are in highest demand in-person, neurology and developmental and behavioral. And it's because the ratio of need to specialists is such that it's truly supply and demand economics.
Perfect. How can one work with a children's hospital with limited workforce in many of the specialties when they already feel stretched thin, and telemedicine is seen as more work when the providers are already feeling overwhelmed?
Okay, that question, I think, speaks to everything that I shared. I feel your pain. That is why we took on this. We're going to have to do everything. They don't, they may have great intentions, but their plates are so full, they can't start a telemedicine initiative. And then you have the pushback from maybe their staff nurses that don't want to facilitate. And they need a trained, trusted, a facilitator they have a rapport with. Maybe you have to hire one that will travel if you're partnering with other organizations or locations that you don't own. But you really have to have that centralized telemedicine department that can remove those barriers and just take care of everything that has to be done. I say a lot of times, would you start a new service line without a director or at least a manager and some nurses and some care assistants and an access rep? No, you would not do that. But I know lots of organizations that have a part-time physician that's dedicated, has 50% time dedicated to telemedicine, and is expected to lead and build a telemedicine program. That's crazy.
Okay. Morgan, when you first initiated operations, you obviously didn't have the entire team listed on your one page. Who do you think you need to start with as a core team or when starting a new program?
So in the very beginning with that one patient that I inherited, it was me and a part-time medical director and a technical person, which in hindsight didn't have enough work for the technical person for his level of skill. He was instrumental in helping make some decisions, but after that part, there just wasn't enough volume or business to keep him engaged. So if you have a technical resource that you can borrow from your IT team, or maybe share it so you have that person in the beginning 50% of the time. Because you do need that. I didn't know anything about levels of encryption and packet loss and that type of stuff in the beginning. So I had to drive someone crazy asking all those questions and helping me find the resources to answer those. So in some capacity, you have to have a technical person, and then obviously the leader, the coordinator, the manager, whatever you want to call that position. And then the next person that was hired to join the team was a training coordinator, someone to work with the providers to teach them how to use equipment. In the beginning, I did everything except for the technical piece. I was the facilitator, I was the trainer, I was the coder, biller. I exaggerate a little bit, but truly. So I think to sum it up, you need a coordinator, a part-time technical person, a physician who can justify your needs. And it was really, really helpful to have, I call it, the bat phone straight to the top. Because if I really needed something, I could go to the CMIO to make my case in an audience in the beginning that I was not prepared nor qualified to address.
Okay, thank you. When you onboard a new telemedicine clinic, How long does it typically take for the clinic to be functioning and operational on a consistent basis?
We like to tell providers it will be 6 weeks. And the biggest reason for that is most of the time they already have patients scheduled 6 weeks out, and we have a policy in the organization stating that we can't change schedules more than or less than 6 weeks out. So we couldn't cancel those in-person encounters if we needed to open up a telemedicine template. The other part that slows things down a little bit is med staff. We can get them trained, but they have to then apply for credentials and complete their SPPEs. So, but we can do it in 6 weeks. We could probably do it a little faster, but those barriers prevent us from.
Morgan, another question. What is the process to add subspecialists to the system, and what are the requirements, and how is compliance with HIPAA and different state regulations addressed? Okay,
I kind of missed a little bit of the first part of the question. Could you say that again?
Yes, it's what is the process to add subspecialists, and what are the requirements for HIPAA compliance, and how are different state regulations addressed?
So HIPAA compliance is the same as it would be for in-person because we've already made the choice to purchase and work with only vendors that are encrypted and meet the standards for HIPAA compliance. So the technology is HIPAA compliant. As with all HIPAA violations, the biggest risk is human error. So we really don't treat it any differently than all of the other HIPAA education that we have within the organization, if that makes sense, because we own and operate both ends of this picture, so everyone has all of that training and education and understands privacy. And then the conduit that we've provided is encrypted in such a way that we don't have to worry about hackers. Not that you can always hack something if you want to bad enough, but the risk is so tiny that it's a non-issue. Interstate licensure is awful. Recently, we hit like the 50% mark as far as states that have joined the medical licensure compact. That doesn't mean you don't have to get a license in the state where the patient's located, but the compact is supposed to make it faster. So if you state that you want a license in Nebraska, for instance, because you're going to be doing teleradiology, then Nebraska, and I apologize, I can't remember if they're part of the compact or not, but if they are, the idea is that they're going to process that application faster, which is a huge step in the right direction. We have to go through the same process that everyone does, and it is a hassle, but we have providers that are supporting, we have child abuse and neglect specialists that are supporting some advanced practice nurses in Illinois, and it took 2 years from start to finish to get the contracting, the credentialing, the licensing. It was all those things that you read about that are barriers to telemedicine. But I had a provider that was a true champion and was willing to wait and understand that this was not my fault, that we were doing the best we could, and eventually it worked out.
Good. Morgan, I'm going to ask a question. I know
Did I answer all the questions?
I'm going to ask one last question. Do you think that children's hospitals could collaborate in providing specialty services and thus share the responsibility of providing access to specialists through collaborative arrangements?
Oh, LuAnn, you did. You know how I feel about this.
Yes.
Loaded question. I would love to see a national and then eventually international telemedicine collaborative where the specialists, because, you know, if you're in specialty medicine at all, you appreciate that there's specialists and subspecialists, and then there's like these crazy super specialists. Like we have a kernicterus specialist here. He's like one of only 3 in the whole world, okay? There's no way people can come to us. Let's get him out there. And I'm sure Boston Children's and LA Children's and CHOC, and I don't want to leave anybody out. Everyone has a specialist that nobody else does. So let's use telemedicine to get those kids the care that they need. Just saying.
That's amazing. Well, we have several additional questions that came in. Scott or Rachel, if you're on the line with InTouch, I'm not sure if we have time to field additional questions or if we can just follow up with responding to those questions.
Yeah, we'll be able to follow up those questions individually via email, so we can get to those after the event. So with that, I think we're pushing up to the hour, so I'd like to thank everybody for joining us, and especially a big thank you to Morgan and LuAnn for today's presentation. And like I said, if you do have any questions additionally, you can email us at the email address on the screen right now, feedback@intouchhealth.com. And this concludes our webinar, and everyone have a good rest of their day. Thank you.
Thank you, guys.